Thanks for listening to the Granite List.Live. Today's episode is brought to you by Connect Healthcare Collaboration, where benefits marketing meets clinical advocacy to drive effective employee engagement.
Welcome to another episode of the Granite List.Live. And I'm Leigh, your host today, and I am thrilled to be joined by Kelley and Javier Lira of Texas Medical Management. Guys, thanks so much for joining me.
Thank you for having us.
Sean, I'll start with you. Tell us a little bit about yourself. You're the founder of Texas Medical Management. Why did you start this business? What problems were you seeing in the employee benefits space?
Well, so I had a previous career as an entrepreneur in a couple different industries, and I got into healthcare when my brother was finishing his training. He was 38 years old. He's a craniofacial surgeon. So I came to Austin, and I ended up running two service lines, the adult neuroscience service line and the pediatric. But most of my time was spent, probably 80%, on the pediatric surgical subspecialty side, which is where my brother was and all the different surgeons we recruited into what is now Dell Children's. During that time, I got to see how much money was being spent and wasted on the hospital side, especially in big systems. Not only were the surgeons and all the different staff and everything super expensive, but there was just an inattention to what I call cost accounting. So how do you figure out how to reduce cost without affecting the outcome? They didn't even know what that was. And so as a result, when the Daughters of Charity left Austin in 2014, I left. And my brother and I had been kicking around a couple ideas. And so we landed on this. We had both heard of Dr. Keith Smith at Surgery Center of Oklahoma. And so we called him up, made the trip up to Oklahoma City and met him, talked to him. And he told us, look, I'm surprised this model hasn't taken off more. I'll teach you everything I can. And he's been a very, very good mentor to us over the years. The difference that we have over his model is we don't own facilities. He owns Surgery Center of Oklahoma with his partner, Stan, and then they bring in surgeons to be on their medical staff. So what we do is we go out and identify really high quality surgeons and then build the episodes of care with different facilities. So the primary reason that my brother and I both thought that we could have an effect in the healthcare market was we thought that reducing costs would be very simple. I think there's some very simple arbitrages in the surgical space where instead of doing it at a really high cost hospital, you would take care of the patient at an ambulatory surgery center, for instance. But I think probably the two areas that we thought we could have the biggest impact that would ultimately be the success of the business was we thought we could affect quality. And then we also thought that the service level in this business is atrocious. And so we wanted to improve on that. So we had done some of that work in the pediatric space by getting really good surgeons and then having staff that paid a great deal of attention to the experience of the patient, not just get them in, get them out. And so ultimately, it was that differentiation based upon quality that really lit my fire. It was the reason I spent the last decade doing this.
Quality is a really hard thing to measure. What sets you guys apart and how do you measure quality?
Well, so one of the things that we started with was that surgeons know good surgeons. And it's not always because of reputation or anything. They can make a couple phone calls and ask a lot of people that will actually have eyes. So my brother is a reconstructive microsurgeon. So in his case, he was the reconstructive surgeon. And then in most of those surgeries, there was another surgeon across the table who was like taking out a diseased femur. And then he was taking ribs, hip, and tibia and rebuilding it. So he had a pretty good idea of a lot of the specialists here in Austin, but obviously that didn't extend beyond Austin or even into some of the more different specialties. But what we did was that first group, we had a really good idea of their quality. After that, then our next CMO was Dr. Rick Schultz, and he came from the Baylor Scott and White system where he was the chief of orthopedic service line for many years. And he had added a whole lot in terms of what it means for us to vet, interview, and then select quality surgeons. But we believe so much in our model that in 2018, we started collecting what are called patient-reported outcomes, PROMs. We also collect a net promoter score as well, and we do a shared decision-making set of questions. And so we've been collecting this information for 7 years now, and the outcomes reports bear out the quality that we have. Now, the reason I wanted to focus on positive outcomes for quality is when I first got into healthcare, I was shocked that what passed for quality in a hospital system were no infections, no return to surgery, no surgery on the wrong side, no errors. So it was basically what I call safety measures. I don't buy a car because it doesn't blow up. I don't go to a surgeon because he doesn't get me infected. That's an expectation. Now, of course, we measure that information on all of our surgeries, and our infection rate is extremely low. And so those are important data points, but they don't get at what the real issue is, which, a patient has a problem that maybe one of the treatments is a surgery. And so when we get the patient with that specialist and they make a proper diagnosis and appropriate treatment planning, then it's the execution of that treatment where we see the positive results. So that's why PROMs are so important for us to not only monitor the quality of the surgeons, but also to show our clients that they don't just send us, their members and we just send them to any old surgeon that we can find that'll take our price. That's not the case at all. We care deeply about quality, and it's in our DNA, and it'll be something that we stay with us.
What would you describe as your typical clientele? What kind of groups do you service most often?
Well, we service more or less the mid-market. So that's anywhere from 50 to 100 employees up to 5,000. What I've learned over the years, once you get over that 5,000, there's a special group of brokers out there that are very, very smart. And so some of those big corporations don't tend to innovate in the same ways as more the mid-market. And it's mid-market who are self-funded with an independent TPA. If you have one of the BUCA ASOs, like United or Blue Cross, Cigna, Aetna, and you have their TPA and you have their network and you have their medical management and you have their care nav, at that point, they're going to make less money by allowing patients to come through us, a direct contract with the employer, than they do through their own infrastructure. And so there's very little incentive for them to do so, and they'll fight it. But typically it's independent TPAs who are willing to pay the claims of direct contracted providers. And so we believe that the fundamental relationship is between the provider and the employer, the risk-bearing entity. And that takes a lot of different shapes and sizes and things. So I always tell everybody, if you've met one of our clients, you've actually met one of our clients. There's an evolution going on in the marketplace right now, and it's very interesting as someone who is a student of business and economic history to watch it unfold. And when I started 10 years ago, it wasn't like this. And today I'm going to Health Rosetta next week. And, it's like that started off, it was like 15 people in a room, and now it's like 800. So I don't think it's a controversial statement to say that the BUCA companies and their networks are not doing a good job of helping the fiduciaries of health plans follow those fiduciary obligations. And so more and more, we're starting to see them diverge and go outside of those. And that's where direct contracted providers like TMM can create value for the plan and the members.
For sure. What type of procedures do you cover?
So we cover pretty much anything outpatient for sure. So we're not in the market of plastic surgery. We're not going to do cosmetics. Eyes has been Beth already has kind of a market to itself, but general surgery, orthopedics, ENT, urology, GYN, pretty much all the specialties. Because, we're grabbing doctors that are already in the big systems and they're just independent. So they're already the surgeons that do these bigger cases and are providing a service for us because of the value that we add for them. And they provide all those services for us. Because, as we vet, and we were talking about vetting before, Dr. Martin McCary wrote the book, Unaccountable, and talked about the best people to ask are the people on the ground working with these surgeons, right? So, I have different, especially around Austin, and I know people who make some phone calls and do that kind of stuff and get a hold of people. In addition to that, because I've been in the OR for a while, I can start asking some questions, how do you feel about this? When do you use this? There's leading questions I can get to kind of see their decision making. Are they going to be a person that needs all kinds of implants in the room? Are they going to need, a lot of stuff? Those kind of questions that I think Sean calls it a fastidious doctor. I remember I was interviewing a guy and he's like, oh yeah, when I do this, I use this. And when I do this, I was writing everything down and I just stopped because I knew we were not going to work with this guy because he was just too needy and he was going to add way too much money to what the ultimate bundle that we're trying to create for this patient.
Yeah. And Leigh, a good example of that is robotic surgery. So, it's a very controversial implement in the OR. There's not a lot of data that shows it's actually of value. But we have a general surgeon here in Austin who, when he said, I want to start using the robot, our CMO and Javier were like, okay, but only when it's appropriate, right? And it's very much that way. And so we're looking for surgeons who are looking to get the best outcomes, but also considerate about the cost implications. We don't ever ask them, no, don't use that versus do use this or use it cheaper or something. We never do that. We just ask them that all of this cost goes into our bundle, which is essentially a price in a marketplace, and that we ask them that they be good stewards just as we are with our cost and building up that price so that we can compete in the marketplace.
A lot of times they don't understand cost. A lot of times they don't even know. It's hidden to them. They just do their job and they move on. And I actually had a surgeon tell me that, when I use a robot, this particular hospital system says it only adds $500 to the case. Well, that means the normal one is 10 times more than it should be. And when you're adding a robot, and they added $500 on top of that, right? So it's trying to educate them and let them know if you're going to do it this way, no one's going to come to you because it costs too much.
Yeah, that's really interesting. And maybe that's one of the reasons that healthcare has gotten so expensive is because nobody knows how much it costs, including the doctors who are performing the procedures. And what happens? So you've got, bundled pricing, a stated rate. What happens if the inputs are higher than the stated price? Heaven forbid something goes wrong, or you get in there and realize that it's not exactly what you were expecting. How does that affect the end price?
There's two scenarios that we're talking about. So the scenario is I didn't do a good job estimating, or we didn't as a group, where we did miss something or do something. That is a price guarantee that we give to our patients, and they are not on the hook on that. We take the hits because we did not estimate properly. So that's one scenario. The second scenario is the procedure changes because of unforeseen something. There was, we haven't had, I think maybe we had one in 8 years where the case actually completely changed. Usually it's an add-on. They actually had to do this. Oh, they found this. And then we just let our client know, and we let them know when the price does change because it's more time in the OR, it's more equipment supplies, all that kind of stuff. And we present that to the client, let them know, hey, this is the new case. And it's still going to be better than what they would get in any other kind for traditional insurance, claims data.
Right. Okay, so is this part of your single case agreements, is the stated price, or can you tell me a little bit more about what these are?
Let me explain kind of a high level to it, and I'll let Javier describe actually what it means. So when we first started this business, there was very little trust. They were like, well, we'll let you guys handle the inguinal hernias, the simple knee meniscectomies and the carpal tunnels. You guys go for it. But there was no thought at all about us doing complex surgery. That's where part of the evolution of this arc has been. So now we're at a different level today. So they understand that the surgeons that we vet and select for the inguinal hernias are actually the same surgeons who are doing these very complex cases. So single case agreements are something where they're not frequent enough that they have like a common name or a common price in the marketplace. Like there's a lot of inguinal hernias out there. There's a lot of meniscectomies. There's a lot of, shoulder slap repairs or carpal tunnels or so on, bunions. And when we get single case agreements, it's typically our care nav channel partners will give us a call and say, hey, this one doesn't really fit into any of the bundles. Can you help? And I'll let Javier take over from there.
Yeah, and sometimes it's with partners that are not necessarily contracted with us, right? So I'm going outside to try to negotiate pricing down as much as possible. So it's either a service that we don't provide at the moment. Like right now, they're asking for a particular procedure that we are not necessarily in, but I'm trying to negotiate that right now. I'm in the process of getting the firewalls. Trying to get to the office, and it's always a struggle, but I've been working on that. In addition, it allows us to work in other states because, we're going to utilize our partners because we have a network of people that are like us in the business in other states and leverage that relationship to try to get these patients the care at a reasonable price for their employers.
And it's really important for single case agreements. The plan vendors, like the infrastructure, the administrators, like the TPA or the care navigators or the case management people, they've seen cases like this before and they've seen them very, very expensive. And so their antennas start to tingle. And that's when they give us the call and say, hey, look, last couple of times these cases went through with some of our other clients, it was, let's say, for over 100,000. And so that's where we start the work of trying to determine whether or not we can beat that. And I'd say when we can negotiate with all the parties, it's probably 95% of the time that we are able to beat that and make it cost saving. I think probably the greatest satisfaction I get is this patient may be going through a big system where it was going to be very expensive, but the patient had no idea about the quality of the doctor. And what we're able to do is redirect them to a doctor who is of a higher quality, validated quality. So even if we're, 10% less expensive, it may not seem like much, but when you're getting better quality, it's typically a lot more than that. But that's kind of the impetus at the plan level. They're starting to get to that next level, like not just hernias or carpal tunnels anymore. It's like, hey, can you guys work on this? And that's where Javier's expertise is absolutely invaluable.
Yeah, quality is priceless. Yeah, and having good outcomes. Mm-hmm.
Yeah, we got a call from one of our clients for a GYN case up in Dallas, I believe. And they were quoted over $100,000 just for the facility. And we were able to do the total bundle for less than 30.
Yeah, that's great. So for these single case agreements, are you just working with employer groups that you already have contracts with? Or in the state of Texas, if someone's looking for a quality provider, will you do single case agreements outside of the typical plan structure employer groups that you already have relationships with?
Yeah, we'll work with anybody. And sometimes it's the start of a relationship. We'll get a call from a consultant or a broker who will say, hey, I heard about you guys, met you at a conference a couple of years ago, heard good things. I got this one case that's just going to be a whopper. Can you help out? And then they get to see us work and see how we pull it together and how the patient gets a better outcome and the patient's satisfied. And the care navigation team is all ecstatic because our client services team has carried the water. And then I think the TMM experience then starts the conversation about, well, why don't we have a relationship? And so that's typically a real good entry point for us because we get to prove a lot of value and then talk about a long-term relationship.
Yeah, and that's great. And you're currently just in the kind of confines of Texas right now, but you mentioned that you've got relationships and a network outside of Texas. Can you elaborate a little bit more on where y'all are going and what's in process?
Yeah, so about 2.5 years ago, we had a customer come to us and say, of all the surgery episodic bundling providers that we work with across the country, and they have tens of thousands of lives and they have them in 36 states. And they said, of all the people we worked with for the last 10 years, you guys are hands down the best in terms of quality, service, and cost. And we want you to take over all of it. So we said, that's a pretty stout order because as a provider organization, it's pretty costly for us to set up shop in another state. So in our discussions with them, what we found out was they really wanted our service. They wanted, first and foremost, they wanted our service. So our client services team are a bunch of surgery schedulers with dozens of years of experience, and they're just phenomenal at pulling together all the pieces and getting it all to the doctor so that we can see what's going to be needed and then move on with the treatment. And so as a result, during that process, we just did basic blocking and tackling homework. We looked up, I knew because of my involvement in the Free Market Medical Association and Health Rosetta and so on, there were a lot of other providers out there. We just didn't know how many. And so we just started doing Google searches, doing AI searches, and so on, and identified quite a few other providers out there. Some of whom post their prices on their website like we do, or like Surgery Center of Oklahoma, and some of which will tell you that they're doing bundles, but they are, for whatever reason, don't post their prices. And so we've used that as a way to make connections with people. And it's a big deal for Javier if I say, hey, Javier, I need a total knee in Raleigh, North Carolina. And he goes, do you know anybody? I'm like, no. So that's like a needle in a haystack. I mean, he's like, who do I call? Right. Well, instead, what if I said, well, we actually have a surgery center in Durham, and we actually have another one outside of Raleigh, both of which publish their prices in the specialty you're looking for. Let's reach out to them and talk to them as collaborators. And then what we'll do from that is then we'll have a service fee that we would add and negotiate in advance with our client as a way of more or less building out kind of a network. I don't like to use that term just because of the legal implications of the word network in this country. But for us, it would be a way for us to have people who understand bundles in a market. Javier calls up and says, I need to do an inguinal or a bilateral inguinal. And they're like, okay, we don't have that price posted, but within a very short period of time, they'd be able to put it together with us.
Okay, so just a phone call isn't necessarily going to determine quality, and just having somebody in the same network that offers bundled surgery. How do you make sure that the doctors in these groups that are outside of Texas are vetted and are going to produce the outcomes that you typically provide in Texas?
Yeah, so it's a great question, Leigh. So what we do is we apply the same vetting criteria that we do for our own surgeons. The only difference is we don't have the extensive interviews, personal interviews. So the vetting criteria, some of which has to do with training, but a whole lot has to do with practice focus. And then the other part has to do, we want to make sure that they may be a really great, talented doctor, but then they're a really bad bedside manner. That kind of cancels things out. So we always look at a collection of their reviews just to get a flavor. We feel like we're about 80% of the kind of scrutiny that we're looking for when we're contracting directly with providers in the state of Texas. But we think it's a far better methodology than just selecting any old one off the list.
Yeah, any better than you're going to get just going into the hospital. Yep.
Usually the doctors in this space have to be better. They're already selling. So just posting your bundles, doing that stuff, and being away from the system puts them in a different light already. They already think different. They already work different, and their offices are usually a lot better about it being outside of the norm of a traditional insurance kind of space. So already we're ahead of the game most of the time. Find that stuff out, and our surveys let us know real quick if it was a bad experience. So that also, as a fail-safe, we thought they were great. Patient outcome didn't come out as great, and or they had a bad review. Just even from our stuff, stuff happens.
As we wrap up, tell me just, let's go to the broker side, because we have a lot of brokers listening. What are some benefits for brokers working with you guys?
Well, we're very, very flexible. So as I said, if you've met one of our clients, you met one of our clients. Just when I think we've figured out all the different permutations of broker coming and saying, hey, Sean, we really need to do this contract with the TPA, the stop loss, the care navigation, the employer, or the employer's parent corporation or private equity group. Just when I think, okay, we've done all the permutations, then, a new one comes up. So we're very flexible when it comes to that. What we're very interested in helping are the brokers and consultants who've been bit by the cost containment bug, who realize that there is literally no way to rearrange the deck chairs again this year with the VUCA plan. They've got to do something different. And once they've made that leap of that intellectual leap, then they're like the best advocate for people like us. And then it's just a matter of matching up the brokers who have lives in the areas where we service and then working together. So we actually got our first lead off of Granite List the other day. You guys published an article about us in your newsletter, and it's that kind of exposure we're looking for and hoping that our partnership with the Granite List can really help us grow.
Yeah. Well, thanks for that. That's excellent. I'm glad to hear that. Okay, so if anybody wants to get in touch, whether it's a broker, an employer, or even maybe a surgeon that wants to expand their base, what do they need to do?
I think the telephone number that we have on the Granite List or on our website is probably a great place to start. If they find my contact information also, I'd be happy to help them. We're a small company. We're about 15 people, so pretty much everybody knows everybody. And so if you call one of us, you'll get to the right place.
Well, great. Well, Sean, Javier, thank you so much for your time today and joining me on another episode of the Granite List.Live.
Thank you for listening to this episode of the Granite List.Live. Access our entire library by visiting your favorite podcast venue or subscribe on our site, thegranitelist.live.